Yeah, good morning. Let me just take a minute. Okay, I'll share my screen first. Is that okay? Yeah, and I'm audible also. Yeah, yeah, yeah. So I'll be talking on endoscopic spine surgery. This is a very big topic, but I'll try to share my experience as much as possible from 2002 to 2020, starting with the disc to the space occupying lesion, starting with a simple single chip camera to 3D endoscope, and how to create a brand. This will be a very good lecture for youngsters. Too many neurosurgeons are there now. When I started my practice in Kolhapur, I was the third neurosurgeon. Now there are 15. It's not a big city, but it's a very small city. So now at each and every place there are neurosurgeons. We have to create our own brand in front of the patients so as to get recognition. This started in 2000. I attended the spine conference in Mumbai, and Dr. John Chu was there, and he operated 3 cases with the endoscopic spine surgery technique. He has his own setup. This is John Chu's system he used to use for the endoscopic spine surgery. But unfortunately, in Mumbai, he used the Distendu set. Everybody was quite enthusiastic to know how it works. That was the first time. He operated 3 cases, and all the 3 cases had CSF leak. That was unfortunate. But the wrong message was there in the audience that, look, this is not that easy. It can be a problem. And nobody thought of it. But still, I worked on it. And in 2002, I went to Bordeaux. After thinking about the transforaminal approach and the interlaminar approach in the broad way, I went to Bordeaux to Dr. Distendu. He is Dr. Distendu. And I also went for the neuroendoscopy training with Dr. Parnesgi. This was the neuroendoscopy training at Mainz with Parnesgi. This is the slide for the youngster if they want to create a brand. So how to choose your love in the practice? Work on the subject which others have not worked on it. So work on the subject which is not explored. Focus on it continuously. Do it persistently. And the most important thing is let others know about it, including your patients. Your patient has to be your ambassador for the rest of his life so that he can bring patients to you. You have to present your work honestly. Honesty and the self-audit is the most important thing. So I started in 2002 with the single chip camera, halogen light, Sony TV. A very crude image, but that was also I was also very happy to start with this thing. Then we started with the canal decompression. We started using endoscopic drill in 2006. 2005, I started with posterior cervical discectomy. 2005, I started with the PECD anterior with the neuroendoscope. 12 cases, but I stopped that. I'll let you know the reason afterwards. 2006, I started with the anterior cervical disc preserving surgery. 2007, I started using HD camera by Stoss, which changed the image quality a lot. 2008, I started using ultrasonic bone dissector by Zuring. That was the initial prototype thing. In 2010, it came into market. 2016, I started using 3D endoscope by a company called Vision Sen. It's an Israeli-based company. But somehow it didn't work with the cost and everything. 2017, I started using 3D converter by Mashida, Japan. It converts the 3D image, 2D image into 3D. October 2017, I started using the 3D endoscope by Storch. It is a TipCam 3D. I have used this for the intradural tumors also since 2005 to 2020, the same technique. So the applications of the keyhole surgery or MISS does not require the latest technology, in the initial stages at least. But it requires willingness to understand the concept. You have to basically understand the concept. And if your patient also understands that concept, it's a brand. It is minimalism with the minimization of the collateral damage. You will have to reevaluate current thinking. You have to use the endoscope generously. And always remember, keyhole or MISS refers to concept. It is not the size of the incision which is important. This is in 2002. I started with the neuroendoscopy. This is the basilar tip after doing third ventriculostomy. A very nice picture, very satisfying. Surgeon is in heaven when you are able to see the pulsating basilar artery when you are endoscopic inside. But somehow I realized that this is not going to give me money. And then I shifted from the neuroendoscopy to spine endoscopy and completely started doing spine endoscopy. And I use this distandus technique. This is the outer tube, this is the inner tube. It has 4 channels, channel for the instrument, channel for the suction, channel for the endoscope. This is just like a laparoscope. Basic principle of a laparoscope, endoscope and the suction is coming from one angle, the instruments are coming at a different angle. So this is the angle between the instrument and the endoscope, which is 12 degrees, just like the triangulation there in the laparoscopy or arthroscopy. This is the set, very few instruments. I think this is the cheapest set available in the market. 2 Kerrison punches, which are routine one, 45 degree, 90 degree, 3 mm Kerrison punches, disc forceps, trocar, pen-filled retractors, and the outer tube, inner tube, with the endoscopic bipolar, which is one of the key instrument. This is how it works. The angle is of 12 degrees in between the 2 instruments, and you can move at the site of the pathology like this. You can move around at the site of the pathology in any direction. So it is a mobile system. You can move cranial, caudal, medial, and lateral. So since 2002, distandus technique, I was more inclined to the spine endoscopy than the neuroendoscopy. It's an air-based endoscopy, and it's a mobile system. It is the only system which can be used for all pathologies: lumbar disc, lumbar canal stenosis, anterior cervical, posterior cervical, thoracic disc, or intradural tumor also. It is the cheapest system which is available. You can use routine instruments, and the anatomy is not foreign to you. Just like laparoscopy, anatomy is the same. You get a magnified view with very small incision. And this is the only system which can be used with 3D endoscope. 3D 4 mm 0 degree endoscope. Now you see, this is what I started with. 2002, single chip camera, halogen light, but still we were happy. You have to understand, you have to judge, you have to have the depth appreciation. This is the lamina. Then we had first workshop in Kolhapur in 2006. This was the Sony TV, with the single chip camera. By conducting workshops, we learned by the feedback from the delegates, and we also learned during the live demonstration. This is the second workshop. This is Dr. Distandu, my teacher. Little bit better camera, 3 chip. This is in 2009. We started using the ultrasonic bone dissector. This is in my theater, Dr. Distandu. 2011 workshop. And this is in 2007 when we started using the HD camera. The image was quite good. We could have a depth appreciation by appreciating the distance between the two instruments and the pathology. You can appreciate here, this is the midline in between the two-side flavum, and this is the lamina. This is a right-sided approach. This is right-sided L4 lamina. With this very good image, we were very happy. And everything changed when the HD camera came into market for spine and neuroendoscopy. Now this is the dura underneath. Now the same case, I am putting the endoscope inside the disc space. This is the traversing route. Putting the endoscope inside to have a look at the remaining part of the disc, if there are any loose particles. These are the end plates. We started using this technique for canal decompression by angulating. We used to go on the opposite side, undercut the opposite lamina and the base of the spinous process with preservation of the muscle attachment and the lamina and facet on the opposite side. You can see this is 2-level decompression through the same incision. This is the nerve root on the right side. This is on the left side. Here I have done a right L5 hemilaminectomy so that I am able to see the L5 and S1 root. This is on the opposite side. I am able to retract the root, and this is the disc space on the opposite side. We are inside the spinal canal. This is the ultrasonic bone cutter to undercut the medial facet in cases of the spinal canal stenosis. This is the hypertrophied medial facet on the opposite side. This technique can be used for the multiple levels, 3 levels. Initially, for few patients, I have used the transverse incisions also. Now, these type of incisions nowadays people are using in UBE. It's a new technique. Unilateral biportal. Multiple levels you can use this technique. These are the 4 levels. You can see in the axial stenosis at 4 levels. I did it in 2019 January. 1, 2, 3, 4 incisions with preservation of the spinous process and the opposite side. And this you can see the patient after 1 year. He is a laborer, he works in farm. So this technique minimizes the trauma, preserves the stability, and prevents the further rate of the degeneration. There is no need of fixation, no need of instrumentation, because we are preserving the stability and the mobility of the spine. In short, these are the list of 1,275 cases in the lumbar region. Excellent results in 96%, good in 2%, fair 1%, poor 1%. These are the complications. The most important complication is the dural puncture. This is in initial 500 cases. This is in later 500 cases. Conversion to open in 2, nerve injuries in the initial stages, spondylar discitis. I have forgotten gauze pieces, 4 gauze pieces inside, which I have to take it outside afterwards. 25 recurrences in 1275 cases. Now I have done almost around 1850 cases, and the recurrence number is something around 49 cases I had recurrence. The same technique can be used for interdural tumor. This is a neurofibroma. We have retracted the dura with the stray suture, small scissor to cut the attachment of the tumor to the nerve root, rudimentary nerve root, and this is the tumor. So I am removing it with the spoon forceps. Now this is very important thing. I have taken a stray suture to the outer tube. It's a big dural rent. We have opened the dura for the interdural tumor. And we can close it with these anasto clips. These are the anasto clips. These are used in cardiothoracic surgery to close the arterial walls. These are 2 mm titanium clips. So the dural, the repair, the closure becomes very fast. So dural closure in minutes, and very tight dural closure. So I use this anasto clips to close the dura in cases of interdural tumors. Now this is the interdural tumor meningioma, and I am using tumor CUSA through the working channel of the endospine. The cord is shifted to one side. I have operated on 29 cases of interdural tumors, excellent results in 28, better in 1, 20 neurofibromas, 8 meningiomas, no CSF leak. This is PECD, which I started in 2005. It's a huge risk. At that time in 2005, to treat myelopathy, cervical myelopathy with technique of PECD was contraindicated. But still I used it. This is a disc with cord compression. This is the incision. Very good results. I did about 12 cases, but there was constant risk of the radiation. The surgeon is standing near the C-arm and with the continuous exposure for about 1.5 hours. So I decided to stop that technique, and then I started now this is the PECD. I use neuroendoscope for this PECD. This is the sheath of the neuroendoscope, radiological guidance and the endoscopic guidance. Here I have removed the disc. But I stopped this technique for the fear of the complications of the radiation, continuous radiation. Then I started using distendu technique for the anterior cervical. Transforaminal approach, uncovertable joint, medial to the vertebral artery, diagonally down. This is the anatomical description of the approach, like a Joe's technique. This was the first case. and this was the disc. It's a nice technique to preserve the motion segment. The nerve root, vertebral artery is here. This is immediately after 4 hours. This patient, he was not able to sleep for about 8 days, continuous pain for 1 month, and you can see the incision here. You can use this technique for myelopathy in cases of cervical. This is a huge disc with cord compression. Patient had right hemiparesis. This is next day morning. No collar, no drain. So this is the beauty of the minimalism in spine surgery. As compared, this is the incision, and this is something like a band-aid surgery. 77 cases, this is the clinical. We have operated myelopathy, 20 cases of myelopathy. These are the results. We have got poor results also when I was very heroic in cases of myelopathy with permanent damage of the cord. 2007-8, when I started using this technique for anterior cervical, I was little bit worried. So I contacted these people from Zurich so that I can have an instrument which will remove the bone, but which will still preserve the soft tissue like vertebral artery and the nerve and the dura. This is the instrument by my name, which was marketed in 2010. This is the ultrasonic bone dissector. Same instrument. Now in cases of a posterior cervical, here I have removed the ipsilateral lamina, and I am on the opposite side undercutting the opposite lamina, and you can see the bone dust here. I have used this technique for hemilaminectomy from C3 to C7 with 2 separate incisions to have a cord incorporation. Total cases 42. Excellent in 35. In cases of myelopathy where there is a permanent damage to the cord, you cannot get complete recovery. Dural puncture in 1. Now this is a case of a posterior cervical tumor at C5, and this is 4 hours after the surgery in the recovery. So this is the beauty of the minimalism. No drain, no catheter, patient can be discharged next day. This is my book about this technique, which was published in 2016 by Time. But still there was some apprehension, there was skepticism that there is no depth appreciation with the endoscope. Microscope is still better. Then came the 3D techniques, which we have 3D endoscope, which is 4 mm diameter, 18 centimeter length by Vision Sense, Mashida and Storz. And there is a 3D converter which converts 2D image into 3D by distorting the image. This is the endoscope by Vision Sense. They use the insect eye technology. I used this technique, endoscope in 2016. Case of a canal decompression, bilateral nerve root, thick flavum, ipsilateral nerve root with discectomy, and this is the intradural tumor. I used this 3D endoscope first for the intradural tumor to judge the depth appreciation. Ipsilateral, contralateral nerve root, and you can appreciate this is a 2D video of a 3D. This is ipsilateral nerve root, this is contralateral nerve root. We are inside the spinal canal, and very good depth appreciation. Then I started using this 3D converter which converts 2D into 3D by distorting the images. This is the screen, this is the 3D converter. And then in 2017, I started using this 3D endoscope by Storz. It is a tip cam. Since October 2017, this is the 3D endoscope, screen, 36 inches screen, 3D endoscope by Storz. It's very light and unique model. So even if you can use it for about cases of canal stenosis for 3 hours, there is no problem while handling the endoscope. I have used this for about 332 cases. These are the cases, every level. 3 dural punctures. So it doesn't mean that if you have a very good technology, there are no complications. There are going to be complications even if you are well experienced. So you have to manage those things. Then I started this workshop, dedicated workshop for the training of the delegates. So in the first day we had cadaver training, dedicated with the very few delegates. 4 delegates on one table, 8 delegates for the course with discussion. This is one-to-one teaching, and we give 3D endoscope for the cadaver training also for a short while. Second day they come to the OT and look at the surgery, each and every step of the surgery in detail inside the OT. So this is inside OT training. Everybody has to look at the screen. These are the 2 3D screens, and each and every step is discussed in detail. And again on third day, you get new cadavers and start with the localization and everything for the full day. So this becomes a very compact program. Now this is the 3D demonstration at Nagpur during the conference with the 3D endoscope. So from 2002 to 2020, I have created this 3D endoscope as a brand with the intraoperative explanation of the pathology to the patient relative. In my OT, each and every case I have registered, one of the relatives comes into the OT and tries to understand the pathology. I am more aggressive with the technique but more selective with the results. Where I am going to get results, I operate those cases, but where I am not going to get the results, I don't operate these cases because it defames my technique. Again, I started with the first slide with the John Chu's technique. This is the new technique with UBE, 2 ports, one for the endoscope, one for the endoscope. So everything revolves around the same thing. There is a channel for the endoscope, there is a channel for the working instrument. Here they have broken down the 2 things. In distant view, it is a single unit. So basic anatomy and philosophy, physics of the technique remains same, whether it is John Chu's technique, distant view technique, or UBE. Now there is a role of new technology, 3D endoscope. It will help in minimizing the steep learning curve in the young surgeons. Ultrasonic bone dissector, it will minimize the complications related to the mechanical trauma to the soft structures like vertebral artery and the nerve root or the dura. Robot, nowadays only navigation and robot we are using it for the particular screws only, but if we start using this to judge how much bone we have to remove, which is compressing the neural structures, that will help us in minimizing the excessive removal of the bone, and it will preserve the stability. Now, there is an exploitation of the technique also. Technique as such is not bad at all. The selection of the patient may compromise the technique results. So, technique is not bad at all. Exploitation of the approach to achieve the imaginary goals will compromise the results of the technique. This the youngsters should understand and realize. So the exploitation of the technique is there. Don't blame the technique, because technique is not bad at all. Any technique, whether it is percutaneous technique, whether it is the easy go, whether it is the distant use. The examples are the MISS with the intradural SOL. When you are expert, you will be able to do it. Initial stages, it is not possible. You cannot exploit the technique as the others are using it. Bilateral transforaminal fixation. Now, this is a transforaminal approach. Now, this is a neurofibroma. One of my friend from Italy, he is doing it. This is possible because this neurofibroma is in the foramen only, but this is not applicable to all cases with the use of the transforaminal approaches. So you have to select your patients carefully. Then the technique is the best technique. This was in the foramen, so he could remove it. Now in India, everything patients wants as a free thing. Where is the MIS like to go in future? If the outside factors like the cost of the surgery, the steep learning curve, everything we can control, it has a very good future. Even the best company with the microscope, they are thinking of endoscope, 3D endoscope, incorporated into the microscope. So they have microscope, exoscope and endoscope together. So endoscope you cannot avoid in future. And there are few slides where we can have critical comparison with the distant use technique for the beginners. One is the skin incision. Second is the local anesthesia or GA for the technique. The cost of the instruments, endoscope size, whether it is a 0 degree, angulated, 4 mm or 2.7 mm diameter. Endoscopic exposure at the site of the pathology. Wet or dry technique. True pure endoscopic technique or endoscopic assisted. Versatility of the technique, learning curve and complication avoidance, and the modification with the technique. First, we will go to the skin incision. Does the size of the skin incision in millimeters matter the final outcome? I think after 18 years, I can say no. One should not consider the size of the incision is important. What you are doing at the site of the pathology is very important. When you minimize your skin incision, you use delicate instruments, smaller endoscope, and there is a limited vision. That one should understand when he want to choose the technique. Now this is the incision for the interlaminar, this is for the transforaminal. There is nothing much difference, but still the surgeon has to understand the technique and choose the technique. Whether it is the technique under local or GA. The local anesthesia role in all types of spinal pathology treatment. Is local anesthesia is in the technique is compulsion or real necessity? Surgeon has to understand this thing. GA by very good anesthetists in our technique, patient can be, we mobilize patient after 2 hours without any catheter. We don't catheterize patients. In very few patients who have medical morbidity, then we catheterize them. Cost of the instruments, it is also very important. The recurring cost of the instruments is very important. If there is recurrent cost of the instruments, because if the instruments are delicate, that incurs to the cost of the treatment also. The smaller the incisions, smaller and delicate instruments, breakage is more expected. Now the size of the endoscope. In distant view, it is 4 mm diameter, 0 degree, 18 centimeter. Angled endoscope in various techniques. where the instruments go parallel to the endoscope. In distant view, you can move around each and every direction. Exposure at the site of the pathology. Smaller the incision, the endoscope is smaller, the exposure is limited. For wider exposure, newer techniques like UBE, stenoscope, they use wider sheath and wider working channel up to 15 millimeters. So if the exposure is adequate, then tackling of the pathology is better in cases of canal stenosis, cervical and SOL. Whether surgeon wants to use a wet or dry technique, this is the differentiation which is going on. Whether it is a dry technique or wet technique. Wet is like transforaminar, interlaminar, where they use irrigation, like in stenoscope, or whether it is a UB. Wet, there are limitations to treat the dural tears because you have to convert it into open. With wet, you are not able to tackle the dural tears. It's very difficult. In dry, if you have very good muscle separation, you are able to treat the dural tear like a open technique. Another terminology is true or pure endoscopic or endoscopic assisted. True or pure endoscopic. No exact evidence to accept this terminology. In laparoscopy, we never termed as a endoscopic assisted laparoscopic surgery. When endoscope and instruments are parallel to each other, people term it as a pure and they need angled endoscope. In endoscopic assisted, we get a wide exposure and mobility. Versatility of the technique, whether the same technique can be used for all the pathologies like lumbar disc, lumbar canal stenosis, multiple level stenosis, posterior cervical and everything. In distant view, we can use the same instruments for all the pathologies. Learning curve, each and every technique, even it is distant view or other techniques, they have learning curve and it becomes steep in the initial stages. All the techniques have learning curve which is steep. Orthospinal surgeons, because of the arthroscopy, they have a less learning curve. Neurospinal surgeons, because of the microscope and the fixed vision, they have a little longer learning curve. The cadaver courses with the hands-on are very important. Now, how these steps to overcome the learning curve in each and every technique, whether it is distant or others. Attend courses, study the anatomy, endoscopic anatomy, indications and potential complications of MISS. Practice on the plastic model or cadaver. This is one of my friend, Dr. Thiraviam, has developed a cattle model, which he has prepared in 150 rupees. So you have to have your innovative, your ideas to come out of this steep learning curve. Visit the experienced surgeon currently performing these procedures, and if possible, perform your first few cases in presence of him. The last thing is modification of the technique. I never thought that the distant use set can be, I need any modification. But it can be used with, the 3D endoscope. It can be used with 30-degree endoscope. We can use a smaller size distant view version, which is called as a endospine duo. So these modifications, as per your requirement, you can do it. Just have listen to the video and the audio. This is regarding multiple technique or one technique. Dr. Ramani's explanation is one surgeon should pick up one technique which can be familiar to him. He should stick to that technique. So you have to pick up one technique, keep persistently doing it. So there is no need to be master of all technique. You have to be master of only one technique and use the newer gadgets to create your brand. So in the search of new gold standard, are we exploiting the techniques? Are we falling prey to the industry in search of a minimalism in spine surgery? Or are we helping patients in the name of minimalism in spine surgery? We have to discuss and answer ourselves these three things. The philosophical conclusion, but its reality, the real golden standard. Our final but unreachable goal is 100% success, which is not possible at all. But our reachable goal is everyday learning, training, and improvement. So we cannot say that this is a golden standard, this is the diamond standard. We have to select our patients and as far as possible try to give the maximum results, but trying to get 100%, but it is a philosophical reality. Now in post-corona practice, we have to be ideal case for the results. I operate free if there are no problems of money, the patient has no money. I don't use any government schemes and other things. A patient which is operated by me free, if the selection is good, he is a brand ambassador for my technique for his whole life. I avoid cases which with the compromised results like compromised myelopathy. And as I am having my own unit, the working cost of my unit is very minimal. I can refuse the cases where I am not going to get results. Otherwise, you need cases to get break-even maintenance for the big setups. Thank you. It's a big lecture. Yeah. Are there any questions? Yeah, sure. Yeah. Yeah. Good morning. Good morning.